So they are also called epileptic. So as per ILAE, patient who presented with 2 or more unprovoked seizure at least 24 hours gap, patient with a single seizure with the risk of future recurrence about 60%, and epileptic syndrome, they are called epilepsy. Then whether it is a single seizure or epilepsy, that is another question. Most people with epilepsy are diagnosed after a major seizure. Usually patients are relative take into account only the generalized tonic-clonic seizure as epilepsy. Transient unawareness, myoclonic jerks, they may not take it as an epilepsy, they will be under-reported. So, whenever before making, even if it is a first seizure, you have to ask all these questions. Then idiopathic epilepsy have a age-specific onset, favorable response to anti-epileptic drug, they have normal imaging and presumed genetic etiology. So, there are many groups of idiopathic epilepsy. Symptomatic epilepsy have a known underlying cause, such as mesial temporal sclerosis, cortical dysplasia. They mainly have focal seizure, often resistant to drugs. So, partial means actually it is a focal onset. Now the term partial is removed. Now it is comes under focal seizure. So the seizure of the brain, whereas generalized seizure, the seizure activity simultaneously occur in both cerebral hemisphere. It starts from deep subcortical structure and spread to both cerebral hemisphere. So it is called a generalized seizure. Here always the patient is unconscious state. Here it may be conscious or impaired conscious. So the partial, simple partial, complex partial is all this type of seizure. After 20 years of, so this is the seizure originated localized, that is called partial. Sometimes it starts partially, focally, and then spread to cerebral hemisphere. Then opposite to cerebral hemisphere through corpus callosum become generalized. That is called partial become generalized. Callosum become generalized. That is called partial become generalized. Primary generalized seizure here starts simultaneously. So EEG has generalized epileptic form activity. After more than 20 years, the new classification was introduced in 2000. The new classification was introduced in 2017. So the partial is removed. Now it is called a focal onset. The partial is removed. Now it is called a focal onset. Then generalized seizure becomes generalized onset. Then they put the unknown onset. Unknown onset means no unwitnessed seizure. Suppose a seizure occurring during sleep, nobody sees whether it is a focal or generalized. They are called unknown onset. Once you came to know the next seizure, you came to know the clinical semiology. It may be put under focal or generalized seizure. Then focal onset again classified as with the awareness and impaired awareness. So generalized seizure, then it once again it may be motor, non-motor or focal to bilateral tonic-clonic seizure. This is the classification given by ILAE 2017. Then 2025, once again ILAE modified this classification. Certain key features in this feature are the generalized onset is removed from the name of 4 main seizure classes. There is a distinction by classifier and descriptor. What do you mean by classifier? What do you mean by descriptor? Classifier reflect biological and clinical categories used to classify the seizure. For example, focal seizure, generalized seizure like that. Whereas descriptor means specific feature within the seizure type. For example, consciousness, impaired consciousness with consciousness. Dichotomy is replaced by observable and non-observable manifestation. Observable manifestation and non-observable manifestation. Observable manifestation means what which is visible to our eye. That's the observable manifestation. Non-observable, for example, feeling of deja vu phenomena. Seizures are described by a chronological sequence of signs and symptoms rather than by solely on the first So classifier, whereas descriptor means specific feature within the seizure. For example, the seizure may be tonic seizure, clonic seizure, myoclonic seizure, atonic seizure. So they are called observable manifestation. For focal seizure, awareness, level of consciousness during the seizure. So this is the new classification: focal, unknown, generalized, unclassified. The unclassified, focal, unknown, generalized, unclassified. The unclassified seizure they are considered unclassified seizure. So we will start with the focal seizure. Focal seizure once again divided into motor, sensory, autonomic and psychic. So this is video will show the feature of focal seizure. So the consciousness is preserved, patient having clonic movements of the face. So probably left motor area, the lesion may be in the left motor area. Then another one is complex partial seizure. Now it is focal with the impaired consciousness called impaired awareness. So this seizure differs from other seizure. One, the patient may have aura. It occurs in
இப்ப இந்த இது வரல. கணக்கு இப்பதான்
absent seizure. This is one of the seizure, generalized seizure, occur in children with 4 to 14 years of age, sudden onset, sudden resolution, there is no aura, no post-ictal confusion, occur 10 times, 20 times the same day, precipitated by hyperventilation. The child has normal intelligence, the EEG shows with the absent seizure with the 3 Hz spike and wave, no need to do MRI. It is a 100% diagnosis. So I will show the video of absent seizure. So sometimes the absent this differs from typical absent seizure. Gradual onset, EEG may slow spike and wave. The children may have cognitive impairment. There may be mixed with the other atonic and tonic seizure. Then myoclonic seizure. This is another type of seizure where shock-like contraction group of muscles, particularly sleep deprivation, provoke the seizure. So particularly after delivery, many patient mothers sleepless, they are prone to develop this type of seizure, particularly JMA, which is precipitated after delivery. So here there is a shock-like contraction of muscles. So the myoclonus sometimes in focal or even sometimes generalized myoclonus. Then generalized tonic, previously called a grand mal seizure. So this seizure is a dangerous seizure. Start with the generalized seizure activity followed by loss of muscle tone. Immediately patient will fall down. There will be a spasm of the respiratory muscle which will produce ictal cry, followed by tonic contraction of the limbs, followed by intermittent clonic phase. So So this is the video shows the generalized tonic-clonic seizure. So after the seizure, the patient may be sleepy or exhausted feeling, or it may be confused state. So this is one of the, particularly the tonic stage is very dangerous. Sometimes only the patient may have tonic seizure, sometimes the patient may have atonic seizure. So this seizure also very injuries, forehead, broken teeth, all this is more common during this seizure. You can see the video of So the person suddenly fall without any precipitating anything, with the impaired consciousness. Then we have comes across psychogenic seizure. Now the psychogenic seizure is called a functional dissociative seizure. Okay, functional dissociative seizure. They are sudden, involuntary episodic events associated with motor, sensory, mental, autonomic manifestation without the epileptogenic discharge with a neurological or non-medical cause. That is very important to say. It is a functional dissociative seizure. There should not be a epileptiform discharge from the EEG. So the patient with this disorder exhibit functional alteration of CNS and reduced self-control. It is underdiagnosed and undertreated, confused with epilepsy, as they resemble epileptic seizure. Unlike epilepsy and convulsive syncope, functional dissociative seizure is not caused by neuronal hypersynchronization. Instead, it results from complex neuropsychiatric dysfunction. It can be diagnosed only when medical cause ruled out. Some other have put a diagnostic criteria to say functional dissociative seizure. Presence of atypical paroxysmal behavioral episode recorded on video EEG monitoring in the absence of electroencephalographic ictal activity, absence of other clinical diagnosis or findings suggestive of epilepsy or other neurological or medical causes disorder in EEG or neuroimaging study. So the ICD-10 classified FDS as dissociative disorder. The DSM-5 places under somatoform disorder. So how to diagnose psychogenic seizure? In psychogenic seizure, there usually in generalized psychogenic seizure, eye will be closed. If you try to open the eye, they will close it tightly, number one. Then the movements are bizarre movements. There may be pelvic thrusting, particularly in female, opisthotonous position. The side-to-side neck movements. They are lasting for hours without any cerebral damage. Okay, they can be brought by suggestion test. I will show one of the video of a school girl. She was touch பண்ண சொன்னேன். அதை ஏன் நீங்கள் காப்பி பண்ணி போட்டீங்க? So in psychogenic seizure, so suggestion test, this is one of the tests which where we can give physical or verbal clue which precipitated seizure. You can see this girl, had this event in the school following asking about the homework. Immediately she fainted. The teacher gave some coffee and sent her to the home. Because of this benefit, she repeatedly did it in the school. So this may be wrongly sometimes treated as a psychogenic seizure. Then, so this is the another video. Where the boys having bizarre movement. You can see it is not tonic-clonic movement. It is not tonic-clonic movement. So body thrusting, the body is lifted from the floor. Okay. So this is called a now it comes under the functional dissociating disorders. So how to diagnose epilepsy? Epilepsy mainly diagnosed by three things. First thing is history. Without a history, you cannot make a diagnosis of epilepsy. So history is very, very, very important. So you must that is the most. Then only neurological examination and other diagnostic tests. The diagnostic test may be so what happened to the person during the seizure, preceding the seizure, or following the episode. So you must ask all these things. Preceding the event, the patient may have premonitory symptoms or patient may have RR. During the seizure, what type of tonic, clonic, okay, myoclonic, like that. Or following what happened, Todd's paralysis or confusional state, all these things you have to ask. Then other question you have to, when did you first experience seizure in your life? What happened immediately following seizure? Then you have to also ask triggering factor like sleep deprivation, flickering light, menstruation, alcohol, and medical non-compliance. That is very, very important. So, you have to also ask what is the seizure frequency? Is there any more than one kind of seizure? What is the maximum seizure-free period? All these things you have to ask. Then past history, the etiology may be different for each group. For example, children, birth anorexia, mental retardation, cerebral palsy, CNS infection, more common. Adolescent, genetic epilepsy, then substance abuse may be common. CNS infection, old age, stroke, metabolic disorder, more common. Social history, alcoholism, all these things you got to ask. So after all these things, first step in seizure diagnosis, when faced with a seizure, primary objective is to really a seizure or condition which is mimicking seizure. So from the clinical symptom and sign presented, all these things, you may come to a conclusion whether it is a real seizure or a pseudo seizure. So these are the conditions which mimic seizure, for syncope, migraine, narcolepsy, hypoglycemia, hypoxia, panic attack, all these things. So family history also very important. You have to ask family history. In unwitnessed epileptic seizure, the physical examination include presence of signs and symptoms that increase the possibility of seizure. Third step is whether it is a provoked or unprovoked seizure. So that is very, very important. So the differential diagnosis always kept. How to differentiate syncope from seizure? This is the Sheldon scale which differentiates true seizure from syncope. You can see scoring presence of tongue bite 2 marks, déjà vu 1 mark, emotional stress occurrence, then dizziness prior to the episode -2, fatigue prior to the episode. So if the score is more than 1, then it is a seizure, with less than it is a syncope. Then other complementary studies, you have to do other blood glucose, complete blood. Then EEG, one of the investigation routinely we are doing, but practically it is 40 to 50% is sensitive because EEG we are recording interictal recording. That is in between the seizure. It shows now it become normal. When the person is normal, we can expect only normal EEG. When the EEG is abnormal in the interictal period, that means it is significant epileptogenic activity. So you have to record EEG within first 24, it will give better results. Then you have to sometimes you have to do serial EEG, ambulatory or sleep deprived EEG, further increase the diagnostic value. Then serum prolactin Suppose a person came with brought immediately seizure, you are confused whether it is a pseudo seizure or true seizure. Sending blood sample for prolactin within 20 minutes, it will be elevated in generalized seizure and complex partial seizure. This is another important investigation. Then suggestion test, what I told you, it also very valuable in diagnosing psychogenic seizure. The neuroimaging CT scan calcified lesion is one of the good screening tests, whereas MRI is the one which better results. Differentiate gray white matter, few millimeter lesion can be diagnosed with the MRI. Cortical dysplasia more diagnosed with the MRI. So imaging is one of the important investigation. So with all these things, this is the approach commonly we will address. Any person comes with the seizure, whether it is a condition mimicking seizure or true seizure. If it is a first seizure, you have to evaluate the patient.
Face classical inverted smile. Just a few attention drawing slides caveats. And this was this is a 30 minutes competition for the young students in our. This boy, Dr. Prithvi. Can I have a music? Audio, please. Please just see the. Just watch this. Doesn't even look at it. 30 seconds. He explains the entire bladder. He won the prize for that competition. So the prize was an innovative clinical neurology prize. And I thought, that's so good. So I thought it's a very good way of lot of innovation. Just leave it. Don't do it. Next slide. No, this is called. This is a very repeatedly asked MCQ questions for the postgraduate. Christmas tree appearance for a hypertonic. You can see that this is the Christmas tree. In a you can watch the. This is the classical Christmas tree appearance. The bladder, you can see the bladder is vertically oriented, the wide base and lot of divertic associated trabeculations forming the pine cone bladder, otherwise called the Christmas tree appearance. In a neurology, and this is the same bladder. So what are the peculiarities of bladder? It has got only you got only two things. It either stores the urine or voids the urine. 99% it is in the storage mode. Less than 1% it is in the voiding mode. So essentially only two things. Lower urinary tract is in the storage phase for more than 99% of continent life. There are a couple of general differences. Men, urinary retention is common. Women, incontinence is common. Just look at the bladder anatomy. Three important muscles are important. One is detrusor, internal sphincter, and the external sphincter. Bladder innervation. What does the bladder sense? Bladder sense only the stretch. The bladder sense, only sensation the bladder can perceive is its fullness. Mechanical stretch receptors were there. But now, complete change in the bladder things is that there is an area called urothelium, which they consider to be a most important endocrine organ. Actually, basically, bladder is an engineering marvel because the urothelium senses several other stimuli. The urothelium, you just look at this. You can have a look. You can see the efferent fibers go to the urothelium, and the urothelium is covered with so many receptors and neurotransmitters. You can look at that. The top list is what is called anandamide. Anandamide is chemical which acts on the endocannabinol receptors producing pleasure. When you are holding it for a strong time and you void, you get a pleasure of voiding the urine. You get relief. You get pleasure. The toilet pleasure, and that is mediated by the anandamide. Anandamide is named after our great Jackie, who said that every emotion as a chemical, and the Nobel laureates who got this chemical, they quoted Jackie in their Nobel laureate lecture. One is anandamide, another is virodamide. Both the chemicals are the one of this receptor is present in the bladder. So you can see this is such a dense organizational things. So many receptors. Endothelium is one of the important endocrine organ, which is these are all lot of things are going around in the therapy of this. The bladder has only two afferent systems. One is the A delta afferent system from the detrusor, sensing stretch, and C fiber afferent from the urothelium and interstitial cells, sensing multiple stimuli. Even the pH of the urine is also monitored. I was really surprised. I never thought. See, the kidney has a lot of functions, monitors everything and sends the urine. Aligned by a transitional epithelium, the function of transitional epithelium is to do nothing. It should neither add nor secrete something. Then the whole purpose of kidneys and all its sensor will go away. So its main is just store it and then stretch. It can stretch and then pass the urine outside. If it keeps meddling with its content, it is going to be harmful. But that's what the function of the transitional epithelium, do nothing, like Arunagiri Nadar who said, Summa Solarama, the most difficult thing is to do nothing. You must see a lot of memes in Vadivel also. Doing nothing is the most difficult thing. That's what the transitional epithelium is supposed to do. But now, it's not this. The function of this is, when your bladder is full, there is a delta V by delta P. Volume and the pressure have an inverse relationship. When the volume is high, the direct relationship, the volume is very high, the pressure is also like to be intravesical pressure is very, very high. The moment one drop of urine comes out of the container, the pressure falls by more than 50%. So this is what lot of containers, the high volume containers, they are looking at how this mechanism, how does you reduce the pressure by a single drop comes out of the bladder, all your drive goes away. Another 10-15 minutes you are free from the no stress at all for your bladder sensation. So the sudden drop of more than 50% in the intravesical business is challenge to people who make boilers and containers. They are doing a lot of research on using the urinary bladder. So that's why I said it's an engineering marvel. The C afferent fiber from the urothelium monitors so many chemicals, monitors pH, monitors temperature of the urine, monitors so many things, and it was just not the stretch. So remember, there are two afferent systems. One is A delta, the other is C fiber afferent. And the afferents, where do they go? They terminate in the dorsal horn, superficial dorsal horn, the intermediate grade in the lumbar, and the periaqueductal gray, which is the switch, the major switch for the bladder. So some afferents also put a small local loop, go to the parasympathetic drugs, and few of them go to gracile and parabrachial nucleus to the posterior column, reach thalamus. Thalamus, you have to be conscious when you are passing urine. So you have to mark a copy to the consciousness. The consciousness is present in the median nucleus in the thalamus, from where the fibers are projected to the cortex. So one of the important who passed urine, I passed urine, and where I am conscious of passing my urine, all these things are done by the thalamus and its connections to the cortex. So that is why the third afferent fibers also go to the thalamus. Two important nucleus. All of you must have heard about the Onuf's nucleus, which is present in the S2, S3, S4 segments, which are the motor neurons for supplying the external urethral sphincter, which never get involved in ALS. There's another new entity is called what is called the JERT nucleus. I will be talking about this a little later, which is also in one of the spinal interneuron centers, which is recently they have found out. The spinal interneurons play a lot of role in regulation of micturition. So the pontine micturition center, periaqueductal gray, connects it to what is called a pontine micturition center, which has got two parts. One is the Barrington nucleus, which is the voiding switch. And the lateral part of it is called the continent switch. There are two switches in that. So the bladder efferents are two. One is parasympathetic, which from the S2, S3, S4 in later horns, pelvic nerve and plexus, parasympathetic ganglia, and short fibers to the detrusor muscles. Second is in the sympathetic efferents, intermediate lateral horn, inferior splanchnic nerve, inferior mesenteric ganglia, hypogastric nerves, and bladder, neck, and the internal urethral sphincter and the detrusor muscles. somatic system is SS2 on-off nucleus, pudendal nerve controlling the sphincter. So these are the three efferents. I have told you two efferents, A delta and receiver, system, sympathetic, parasympathetic, and the somatic. The same is depicted here. You can see the hypogastric nerve for the sympathetic, and parasympathetic is for the pelvic nerve through the pelvic nerve, and the pudendal nerve for the extrasympathetic, the sympathetic, parasympathetic, and the somatic. And the same is in the direct diagrammatic. You can see this is the diagrammatic response of this. Then just add the chemical transmitters. I don't want you to go into the depth of this. Just remember the M3 receptor, beta 3 receptor, and the nicotinic, the B3 receptor in the bladder, and the N3 receptor in the bladder, the values. So to summarize the innervation of bladder, A delta postganglionic sympathetic and spinomotor are things. So brainstem, there are two regions of interest. I told you